Good morning, everyone, and welcome to NurseTOK for March. NurseTOK is an online CPD for continuing professional development for Pacific nurses. And we've got also the Facebook group, so that's a place where you can know what is coming up in the next NurseTOK, but also share ideas, share questions with colleagues from across the Pacific. So we want to say Nisambula for our Fijian friends. We want to say good fella morning for our friends from Solomon Islands and Papua New Guinea, and hello for our Vanuatu friends. And if you want us to use your language next month, let us know. Teach us. And we're coming to you today from Darwin, which is on Larrakia land. So we would like to acknowledge as guests people on Larrakia land. We acknowledge Larrakia people as the traditional owners where Beth and I are sitting today, and pay our respects to their elders past and present. So in case you don't know, we're in Darwin, which is up the top of Australia there. And we can see people we've got a lot of people from Fiji today, which is great, and hopefully friends from other countries. We're hoping that over the coming months, this can grow so that people across the Pacific are able to get some education. As we've travelled around various places in the Pacific, that's one of the things we kept hearing is we want opportunities for continuing professional education. And so we'll mention again at the end, if you've got ideas of sessions you would like, let us know and we will see what is out there. Today, though, we're going to talk about oxygen, and our aim today is that everyone gets something, because something we've noticed is that different people have different experience with using oxygen therapies.
All right, I guess it's over to me, Anne. So we'll just kick off with just to put the session into context, a brief case study, which is probably going to be familiar to all of you. And the purpose of the case study is, to hopefully try and generate some thinking and some discussion around your experiences with oxygen or not oxygen. So we've got this gentleman that you can see sitting here with his mask on, who presents to your clinic feeling unwell. He tells you he has a 2-day history of shortness of breath, a productive cough, and he does have a history of asthma, however, has not had any hospital admissions with regard to this. So try and keep this case study kind of in the back of your mind there whilst we're working through the rest of the NurseTOK. All right, so I guess the first thing to just highlight is what is oxygen, and also what isn't oxygen. So when we talk about oxygen, sometimes we mix up air and oxygen, and the difference really is that oxygen is only a small part of the air that we breathe. However, we need it. It saves lives, and we can't live without it. So what I just wanted to highlight was that the composition of air is 21%, as we probably all are aware. However, the oxygen we deliver in healthcare is obviously slightly different to that, and it comes in various forms, which we'll discuss later on.
What's the other 78%? Beth?
Oh, what is the other 78%? I knew you were going to ask that, Ant.
I think it's nitrogen.
Oh, that's correct. Whereas with medical oxygen, it's actually 100% oxygen. All right, so there's no nitrogen or 1% of other gases involved with that, and that's a really important point to remember when we go on to discuss later on, so that the differences between flow and oxygen concentration, or another term for that is FiO2, the fraction of inspired oxygen. So the fraction of inspired oxygen, which you may or may not have heard of, is the fraction of oxygen with other gases. So the FiO2 of oxygen in air is 21%. All right. Now a little bit of trivia for you that Ant discovered last night.
I found this riveting. Someone felt the need to write a letter to the editor of Lung, Cellular and Molecular Physiology Journal, which sounds like a ton of fun. And they really wanted to point out that the FiO2 in the I in FiO2 should be a capital I. I thought this was quite interesting because I have never ever seen it written like that. Most people write it as big F, little I for inspired, and O2 for oxygen.
Yes. Thank you, Ant.
Very helpful.
All right. So why might we give oxygen then? Well, I guess really, it can save lives, can't it? That's why we normally give it in our healthcare facilities. And as I said before, without that oxygen, well, none of us would be surviving. And at a cellular level, our cells need oxygen in order to undertake that sort of cellular respiration. So just to put it into context. Oh dear.
You want to go backwards? There we go.
There we are.
One more.
Thank you. Just put it into context. If you think about the concentration of oxygen at sea level, 21% FiO2, as we said previously. If you go to the top of Mount Everest, the FiO2 in the air is still 21%, but it's really hard to breathe that oxygen because the air is less dense, so there's less pressure up in the skies around Mount Everest. So if there's less dense air, but still the same amount of oxygen, your oxygen particles are kind of further apart from each other. So with each breath, you are taking in less oxygen particles, which when that happens, we've all heard of altitude sickness. That's when you can feel really, really quite unwell and suffer the effects of, I guess, a hypoxemia, so lack of oxygen. Did you want to add something, Ant?
No.
Something quirky and clever?
No.
No.
Well, I was thinking you're saying it's like 21% of an amount. So yes. 21% of, if I think of 21% of $100, that's enough to buy a couple of lunches, but 21% of $1,000, I can do something more with.
Yes,
okay.
Definitely. Good analogy there, Ant. And then I guess going to the other extreme, when we might go deep sea diving in the beautiful Pacific Ocean, we obviously carry not oxygen tanks on our backs, but compressed air. And a lot of that, most of that compressed air is air with a little bit of added oxygen, about 32 to 36% maybe. And the effect that has is that it displaces a little bit of the nitrogen that's in that atmospheric air. And the reason for that is that, as we probably know, when you ascend up to the surface of the sea, if you're breathing in less nitrogen, it reduces the risk of you getting the bends. So something interesting that I learned this morning, not being a diver myself.
You're not a diver?
I'm not a diver.
Oh, we need to fix that.
But I think I might be a hobby I might start to take up. All right. So
why might we give people oxygen in hospital or in a clinic?
I wonder, is there any, what kind of situations have you guys come across where you have given oxygen to someone presenting to your facility?
I wonder if people could throw it in the chat, type it in the chat, or just say it out loud. Any reasons why we might give people oxygen?
We'll give you, let's say, 30 seconds, and then we'll have a quick discussion around that. Can you sing a song whilst you're
We need some thinking music, don't we? Yeah. We could play some Air Supply. All right. Addie has, I think Addie said where Addie was from. Yes, from CWMH, ICU.
Great.
Hello.
Hello.
You said asthma.
Absolutely. And I think asthma is something that we have all seen presentations of asthma, whether it's mild, moderate or severe. Addie, I would imagine that you probably see the the bad end of asthma working in ICU, and definitely we would give oxygen at the severe end of asthma. What about people who are presenting with mild asthma?
I've known people with asthma who just need to take their puffer a few times and don't even need to come to hospital.
So what you're saying, Ant, is not necessarily if you've got someone with asthma, chuck some oxygen on, maybe do a bit of an assessment, do some history taking, and assess whether oxygen is needed. Excellent.
Priya has said we need to give it for cellular perfusion. Priya sounds like she could be studying a postgraduate nursing degree, I wonder.
Absolutely. Definitely cellular perfusion. I think we mentioned that earlier on, isn't it? At the cellular level, we certainly need that exchange of oxygen and carbon dioxide in order for cellular metabolism to work and keep our cells alive and healthy. It's a great one. Thanks, Priya.
Do you want to add something, Priya?
No, I'm good.
It's nice to hear your voice.
Yeah.
It's nice to see you finally.
When we say we need to give oxygen for cellular perfusion, the question, I guess, in my head is that means we're looking for signs of when the cells aren't getting perfusion enough. That's our cue when we want to give oxygen.
Absolutely. And again, I guess that goes back to our assessment of our patients, doesn't it? And looking for signs of. And
Praneel has mentioned something about SpO2 not being the normal for the patient.
Praneel.
Do you want to tell us, Praneel? I think it's Praneel from ED in Suva.
Hi, Bula guys. Yep, this
Bula.
is Praneel from ED-CWM. There are different times where we might give oxygen to patients, keeping in mind their clinical presentation and keeping in mind their diagnosis. I wouldn't want to over-oxygenate a patient who's had COPD. So they would have a different normal in comparison to someone of a normal health status. So someone who is a healthy human being, their oxygen normal would be around 94 and above. If it doesn't reach that, then they would certainly require oxygen. Yep.
Thanks, Praneel.
Yeah, and that's a really good point that you brought up there. Not everyone's goal with their SpO2 is the same, is it? So, and again, I think you've highlighted again the importance of doing that assessment on your patient before you pop any form of oxygen on. All right. Any other suggestions or patients you've seen that have needed oxygen in your workplace? So what have we had? We've had asthma, COPD has generated a discussion, cellular metabolism. Trying to think of what I've seen. What have you seen?
I think with COVID, I might have seen some patients who had an infection.
Yes, absolutely. Yeah, lots of oxygen being used in COVID times, weren't there? Definitely. The one that springs to mind for me is MIs. So your non-STEMIs or your STEMIs. But I think there's a lot of discussion out there currently, isn't there, around the need for oxygen in those people, which we'll look at in a little moment. So it's just a list of what the indications for oxygen are, and I guess the umbrella term hypoxemia, really. So saturation's less than sort of 90 to 90%, depending, as Praneel was saying, on the patient presentation.
And I mean, hypoxemia is one of those lovely words, hypo meaning low and emia meaning in the blood. So we're saying that if there's not enough oxygen in the blood, we're assuming there's not enough oxygen in the tissues. But sometimes that's because we're not getting enough oxygen to the tissues, so the lungs aren't getting it in, like with asthma, like with pneumonia. But other times it's because maybe the body's metabolism is too high and it's burning through the oxygen that we're getting. So like in sepsis, maybe in some cardiac arrests and that sort of thing.
Yeah, so I guess that supply and demand aren't matching each other.
I wonder if there's any indications for giving oxygen that aren't to do with low with low oxygen in the blood, so with hypoxemia.
What are people? We'll give you a few seconds to have a think about that and type it in the.
Do you ever give
chat.
oxygen to people who actually are not hypoxemic?
What's that there from AD? Is that
Addie's got lepto and leptospirosis in COVID, so that's on our infection basket.
Yeah, excellent. Thanks, AD. Do you give oxygen to all your leptospirosis patients? Something we're not overly familiar with here. Just
hi.
hello.
Not really. Only when the need arises.
Fantastic. And how do you decide when that need arises? What kind of assessment do you do, AD? How do you make that
ICU, we normally check mostly their SATs.
Great, good one.
Yeah.
And what sort of SATs are you kind of aiming for roughly with those type of patients?
The cutoff, at least it's about 90, 92, 94.
Beautiful.
Yeah.
That's great. That's really good to know.
Well, no one else has said anything, any reasons they give oxygen for reasons that are not about hypoxemia. But I reckon there are some.
Well, funny you should say that, Ant. Here's a list of some that are probably familiar to everyone. So that increased work of breathing, I think is good that that's at the top of the list, because I guess a lot of patients present to clinics or hospitals already who are inpatients who do have an increased work of breathing. And that doesn't necessarily mean that they need oxygen per se. There might be a background reason for why their work of breathing has increased, such as a little bit of heart failure. You know, that's gonna really increase the work you need to get the oxygen around. And I guess another one just to highlight at the bottom of the list is post-operative patients. Someone, or just randomly thinking, someone who's had a hernia repair and is post-operative, do they necessarily need oxygen if they're sat, you know, if you pop a SATS probe on, then they're sat to 97%? Possibly not.
And the one I'm interested in is sometimes we give people oxygen when we're just preparing for the worst, even though their oxygen levels are fine. So if you think of before an intubation, or if you're in intensive care and you're about to suction a patient, we might give a period of high oxygen just to increase the amount of buffer we've got in case something goes wrong.
Prophylactic oxygen.
And we do give it sometimes just to give another medication. So we think about oxygen as being a medication, but sometimes in order to give a nebulizer, if we don't have air supply, and I don't mean the band, I mean an air supply, or if we don't have one of those little nebulizer machines, we might have to use oxygen just to give them salbutamol or something like that.
Cool. All right, so I guess that gives us a nice little avenue into having a look to see how we all have what kind of oxygen supply we all have in our workplaces. So there may be some familiar photos coming up to you all very shortly. The first one, now correct me if I'm wrong, and I think this was taken in...
This is at Colonial War Memorial Hospital in Suva.
Yes.
And they have quite a beautiful oxygen facility there to supply their hospital, because they have liquid oxygen, which is, well, it's fantastic, isn't it? It lasts a long time. There's a great big tank.
Yeah. And I get... It's minimal maintenance, really.
There's a bit of maintenance, but that thing supplies the entire hospital. So they're able to have piped oxygen throughout the hospital.
Yeah.
But across the Pacific, we don't see a lot of liquid oxygen facilities, do we?
No, I guess this may be probably more familiar. So your manifold system, which I saw a reasonable amount of in some places in CWM, and basically how you probably all know how this works, but it uses sort of a primary group of oxygen cylinders, and when, so say the primary group is on the left, and when that pressure drops in the primary group, see with that little indicator at the top there, when the pressure drops to a certain level, the secondary supply will then kick in. So I guess
this is much more common in hospitals across the
Yeah,
Pacific, and it means someone's got to be employed to make sure that that's changing over.
Oh yes.
I remember being in Papua New Guinea, and during COVID, and one of the wards had the oxygen gauge in the ceiling.
Oh, wow.
So every now and then we would go to the nurses' station and look up at the ceiling to see how we were going on the hospital oxygen supply.
Yeah, beautiful. And I guess the one thing that both of these systems have in common is that the oxygen usually comes out of a sort of supply coming through the wall. So you can see there you've got an oxygen outlet on the wall, and you've also got a medical air outlet on this wall. The last type of oxygen delivery that we often see is that supply of bottled oxygen, which is so that's going to need really secure supply chains, isn't it, to be able to supply that to your hospitals. And it's also it is reasonably high maintenance, because you do need someone to make sure that your oxygen bottles don't run out at any time. So you've got to have someone onto it pretty much 24/7, which is a huge responsibility.
And we don't want to spend all the time talking about COVID, but we've certainly seen in COVID this can be a real stress, is making sure that unlike those manifold systems where it automatically kicks over from one bank of cylinders to another, with this system you have to be watching each patient that's on a cylinder and try to judge when the right moment to change the cylinder is. And they can be heavy to move around. Those are the big cylinders. There's obviously, you're used to cylinders of several different sizes.
Cool. And then with the cylinders, with all oxygen cylinders, you're going to need a regulator. Now, the two types of regulators. So you've got your bullnose regulator, which you can see here, which may be being phased out in some places, and are maybe slowly being replaced with your pin index yoke. Now, the pin index yoke, you will have to attach a gas regulator to that at the top, just like said picture here.
Yeah.
So I don't know how.
So which one's better? Because I know there can be a little bit of confusion. And if we look at the next one, you can see the big advantage that's in the depths of NurseTOK Hospital, I think. But you can see they've got bottles of oxygen on the left, oxygen on the right, and air somewhere on the. It says oxygen. No, I think I might be getting tricked up by that one. But the advantage of the pin index system is you can't put the wrong fitting on. So it makes a difference between air, oxygen, and other medical gases. So it's a good thing for safety, but you'll find, I know Fiji's been changing over. Some countries in the Pacific haven't yet started changing over, but there are plans for most countries to change. So it's something to keep an eye on. This one shows how to connect a pin index in case you haven't done it before. They have that thing on the top so you can tell when it's been opened, and you just slide it on, and you can't put the air on the oxygen or the oxygen connect on the air. Screw it on, and then you need to attach a flow meter to that. So the regulator just lowers the pressure, and then the flow meter dispenses it at the rate you set.
And just having had an experience with these pin yokes, it's really important that you make sure the pin actually aligns with the dent in the oxygen.
What could go wrong, Beth?
Otherwise, you could get a great big whoosh of oxygen and you lose most of your oxygen supply. And I say that from past experience. It was very embarrassing because it was very loud, and it did draw a reasonable amount of attention to myself. So whoops. It was a bit of a whoops. but quite a serious one as well. You know, if you haven't got much oxygen around, then it can obviously have quite detrimental effects on a serious note. All right, so some of the things we need to know about compressed oxygen.
You've got to have a supply, you've got to have a regulator to adjust the pressure, and then you need your flow meter. So that's for those systems. And as we've sort of alluded to, they come with their advantages and disadvantages. So know what your system is. There's one problem that both these systems have, and that's that they're expensive.
Yes.
And also freight and delivery of oxygen cylinders can take a long time. So I think I remember correctly, that big liquid oxygen supply for Suva, that has to be shipped from New Zealand, if I remember correctly.
Wow.
And then in places like parts of Papua New Guinea and the Solomons, the supply has to come by barge from Port Moresby. So when you have a sudden surge in cases, you can find that you don't have enough oxygen. If only there was something we could do about that.
How lovely that you've segued into that very well, Ant. Oxygen concentrators. So I think these machines are just fantastic, and we're probably all a lot more familiar with them now since COVID. I know I certainly hadn't come across them before coming out to Fiji, but learned an awful lot about them whilst I was over there. And I think they're great. They really are great. And we have one here to show you. But basically, they tend to be a little bit, I think they're quite clever and magic, really, in that they can create oxygen out of just normal atmospheric air. So the glory of that is that they're reasonably cheap to run. And you can use them to hook up to numerous patients who require oxygen, and you can also use them to increase flow rates above your flow that you have on your actual oxygen concentrator. So I'm a big
Sounds
thumbs
too
up.
good to be true, Beth.
Big thumbs up.
Yeah, well, I reckon there's some problems with them too. They need electricity. So if you're in a place that has an intermittent electricity supply, then you need a generator.
Yeah.
Some clinics only have solar, so you can only have your oxygen at night. They break down. Has anyone opened one of these up? It's quite a mysterious setup in there. When we went to Goroka Hospital in PNG Highlands, there was a whole stack of them broken. And I think a lot of Pacific hospitals have a little corner somewhere with broken oxygen concentrators. What's interesting about that, though, is if you get your biomed guy in, or girl, they can usually fix it in about 10 or 15 minutes, because usually with these machines, there's only a few different things that go wrong. So most of these are actually easily fixed. For example, this model has a internal cotton filter, and bits of the cottony stuff fly off and go up the tubing, and then the tubing gets blocked. So all they had to do was open it up and get a syringe and push that through and connect it back up, and it was go again. But that is a problem with them. But also, they only go up, depending on the model, to 10 or 15 litres. What does that one go up to?
Ours is 10.
It's only a 10 litre, and some patients need more than that. The other problem I've seen is on the patient side, where some patients just don't believe this oxygen is as good as the oxygen coming out the cylinder. And you might change them over to a cylinder, to a concentrator to try and save the pressure cylinders, and then you come back the next morning and they're back on the cylinder because they think it's better.
Yeah, that
I think we need to do a bit of education about that.
Yeah, difficult one to navigate, isn't it? All right.
Here's a fun hint. If you do have a patient who needs more than 10 litres, for example, if you've got this, you can join two oxygen concentrators together using one of these little plastic Y connectors. On the other hand, if you've got one concentrator but two patients who just need a little bit of oxygen, you can split 10 litres into 5 litres or even more by reversing those connectors. And some places actually have a little box, I've forgotten the name of it, that will split it into 4 or 5, one concentrator between 4 or 5 patients, if they just need a small amount.
Right. And I guess in relation to that, then we have the different flow meters that you probably come across as well in your practice. So
they look the same to me.
Yeah, the picture doesn't highlight this very well, but the one on the top left that looks like it has red writing is probably about a 2.5 litre flow meter. So you obviously can only go up to 2.5
for the kids,
litres.
is it?
It is, yeah, little babies. And then the one next to that at the top looks very much like a 60 litre flow meter.
60?
Now, 60.
60.
Whoa. Now, some of you may
Is that
not
like a hairdryer?
Well, do you know, it can give you a reasonably good blast of oxygen, yes. Now, we tend to use the 60 litre flow meters for our high flow machines, which we'll again discuss in a little moment when we look at oxygen delivery devices. But one thing we learnt when we were in BG was
I've seen a couple of patients that were hooked up to a 60 litre flow meter just to a normal mask, and people didn't realise, so they just turned it up.
Oh, yeah.
They're getting quite a blast. Yeah.
Yes, quite because it can dry the eyes out as well, can't it? Sort of blasting that amount of oxygen into your patient's face, and also the patient maybe didn't need all of that.
I don't think they did.
No. So again, maybe looking at conserving,
wasting oxygen.
Yeah. Oxygen. So yeah, what we did in BG, and I think Ada, you probably remember this, is with the 60 litre flow meters, we popped a little bit of nail varnish on them so that we could easily decipher what was a 60 litre flow meter and what was a 15 litre flow meter. And I think that worked really, really well.
It's a good trick. So if you've got to mark those high flow cylinders, you just use a bit of nail polish. One of our male doctors seems to take a lot of pleasure in doing this. The other advantage of that is it's hygienic. So you can still clean your medical equipment as normal and it will last. And Addie says they still have those.
Oh,
beautiful.
Have you still got all of them, Addie?
Some of them might have grown legs and walked.
Cool. Excellent. All right. So we kind of we've highlighted what kind of systems we have that deliver the actual oxygen to the healthcare facility. But now we're going to have a little look at how we actually deliver that oxygen to a patient.
Because the question we want to go is, if we've got to give oxygen to a patient, how are we actually going to give it to them? And we've got some choices. I think of it as a ladder, because these choices give us a different amount. So at the bottom of my ladder, for patients who only need a little bit of oxygen, is oxygen prongs. And here's some I prepared earlier. Can you guys see? Now, I've seen some interesting ways of wearing these. I think we'll just hook Beth up, seeing she looks like she might be a bit hypoxic. A nice way is to put it over the ears and then tighten that a little bit, so that then when she's relaxing on the pillow, if she's in a hospital that actually has a pillow, she's not lying on the plastic. Some people do put that a bit sneakily like this, but I don't think that looks as comfortable. But for some patients, what do you reckon? Is that?
It's all right. I think it would annoy me, when I'm lying down, and it would kind of pull, I guess, up into my nostrils.
Right.
Yeah.
So that's nasal prongs or nasal cannula, or some old people call them nasal specs.
Oh, yes.
I'm not sure if anyone else has got any other names for those. And we can put a few litres through that. The next choice, we call it a Hudson mask, and in different parts, or maybe a normal face mask. And the trick with the Hudson mask, I know you've all fitted it, but what I want you to just have a quick look at, in case you've never seen, is see there's a little hole in the side there. There's some holes, and that's for air to come out. So when the patient's breathing out, my slides keep moving. When the patient's breathing out, we know they exhale air that's got a high amount of CO2 in. That helps release that, so they're not rebreathing as much of their carbon dioxide. So we're all used to that. And the other convenient thing about that, and the next one up the ladder when we're getting a bit more serious. And I know not everywhere is used to working with these. This is called a non-rebreather mask, and it looks a little bit like the Hudson mask, but it has this reservoir bag. I reckon we should boot up our oxygen concentrator. Oh, doesn't that sound nice? So what we want to make sure when we're using these is that our reservoir bag is actually filling up. What that is doing is it's increasing the effective amount of oxygen the patient's getting, increasing the fraction of inspired oxygen. But if we have it on a low amount of oxygen, this bag might not be doing its job. So it won't be filling enough. So if you walk past the patient and the bag looks like that, it's a hint that there's a problem with your oxygen supply and it needs to be increased. And the other thing to watch, the other thing to watch with these is if you look close up, you can see that one of the holes has a little cover on it. So again, if we're not having high, if our patient's shallow breathing, or we don't have enough oxygen supply, that cover won't release and the patient ends up rebreathing their own oxygen. So really important, carbon dioxide, sorry. Really important, why are these slides moving? Really important that that we make sure that if we're using a non-rebreather mask, that we're using plenty of oxygen. And then we have some other high flow options, which we'll talk about in a sec. So this is another way of looking at that ladder. With nasal prongs, we give 2 to 4 litres per minute, generally. And that means that the fraction of inspired oxygen increases to 25 to 45%. So I usually think 2 litres is about 25 to 28%. 4 litres is maybe around 40-something%. But it's very approximate. So if my patient needs more than a higher fraction of inspired oxygen, I can use that Hudson at 6 to 10 litres a minute. I don't want to use a Hudson with less than 4 or 5 litres because it's not going to flush out enough of that carbon dioxide and they're going to start rebreathing it. So, but the most a Hudson's going to get me to is about 60%. So if my patient's quite sick, I might need a non-rebreather mask going at least 10 litres. At least 10 litres to make sure that I'm flushing out enough CO2, but also so that I'm filling that bag enough that when the patient breathes in, what they're getting is something close to 100% oxygen. It won't be 100%, but it'll be getting close. So a FiO2 of 80 to 100%. I think it's pretty, if you work anywhere where you're using oxygen, it's good to memorize a few of these numbers. Isn't that right, Beth?
Oh my God. I know them off the top of my head.
Yes,
yeah.
Most of them. The only problem is, and here's a nice chart that's got them all written out for us, you will see that there's variation between different charts as to what the FiO2 is for different litres, because it's a little bit theoretical. It depends on how much the patient is breathing.
Yeah.
So if here's another hint, if your patient is breathing very fast, if they're tachypneic, the effective fraction of inspired oxygen we're giving on a mask is less.
Yes.
That's different to when we're using ventilators, which can keep up.
Yeah.
So if they're breathing fast, you might need to go up that ladder and use a non-rebreather mask or something similar. Then there's some other devices like high flow, or some of you have seen the Airvo. I think some of you have them in your service, or even non-invasive ventilation. Now, with the Airvo, that's just a brand name, but it's high flow nasal cannula. So to break that down, it's high flow. So some versions of the Airvo can go up to 50, 60 litres per minute.
Correct.
It's through the nose often. So they can be hooked up to masks. But look how happy that man is. And that woman there on the Airvo, I've never seen a patient looking quite so happy on a nasal cannula, because it's gushing up to 60 litres up the nose. And to make this more tolerable and sustainable, it humidifies and heats the air, because your lungs like hot, moist air, And at high flows, your nose can't do that for it. So it artificially heats and humidifies it. So it sounds really good, and it can be useful in some circumstances. And then this is mostly in some emergency departments and intensive care, Beth. You've done a bit of non-invasive ventilation.
Yeah, so your non-invasive ventilation, again, can deliver, I guess, higher flows and higher concentrations of oxygen. And basically the way it does that is you place a plastic mask covering someone's nose and mouth. So it kind of creates a seal around the nose and mouth, and then air and oxygen gets blasted into that mask and can't really escape. So the effect that has is that the oxygen and air get from your mouth to your lungs a lot faster, and therefore improve oxygenation. Some of you, or a lot of you, will have experienced that this type of non-invasive ventilation, it really depends on a compliant patient. It can be quite tricky applying this therapy to someone who is agitated because of hypoxia, or even who suffers from claustrophobia. It can be quite a claustrophobic feeling having these masks on. On the other hand, if you've got someone that's really sick, it can be used to stop them getting invasively ventilated. So it's a really good rescue therapy that you may find in some of your hospitals and departments.
Another hint here, in some places we don't have non-invasive, or for some reason it's not available. But we saw this during COVID. A significant number of the sickest COVID patients, a mask was not enough. We weren't getting enough oxygen saturations. So you can do a trick that we saw first in Port Moresby, which they called it double source. So giving 15 litres or more via the non-rebreather mask, plus 15 litres just via normal oxygen nasal cannula, and that was able to save some lives. Sometimes you needed 2 or 3 concentrators to get that to happen, or a cylinder and a concentrator, for example, but sometimes it was just enough to get that patient through. Which brings us to that question of how do we adjust the oxygen? So we need to monitor and adjust, and we need to do it continuously. And that's where this word titrating comes in, which just means continuously monitoring and adjusting the therapy. So the question is too much oxygen bad for you, Beth?
Look, we are beginning to learn that yes, too much oxygen can be bad for us, not in every circumstance, but certainly in a lot of circumstances. I guess we've always been taught that oxygen is this wonder drug that does save lives, and indeed it does. But sometimes if we give too much oxygen in the wrong situations, it can have bad effects. So oxygen can, if you give too much, and at the moment we don't know how much is too much, but it can release like these things called free radicals, which can interfere with that cellular metabolism again, and actually cause sort of toxic badness. So I guess the question we ask ourselves is, because we don't know how much too much is that, like Ant was saying, and Praneel as well earlier in the session, is to keep continually monitoring and assessing your patient, especially with regard to SATs, to see whether we can actually wind back the oxygen.
Yeah.
You know, if you've got someone who's on 60% oxygen with SATs of 98%, I'd be asking myself, and I'm sure you'd be asking yourself, Ant, well, does that patient actually need that 60% of oxygen? Have we got room to... Well,
the other question I'd ask myself is too little oxygen bad for you?
Well...
And we know that's the case because tissue hypoxia can result in death. So it's about choosing the right amount. And this is something that it depends on your patient. There's no one number. But a simple way of thinking about it, for many patients, we think about a minimum oxygen saturation target of 90 to 93. And we need to measure and adjust frequently to get that balance right, because it will change during the course of the illness, and it will even change during the course of the day. Some patients need more oxygen at night than they do in the morning. So I think of this as a cliff. Now, I don't know if you know that this is a cliff from England. It's a very famous cliff. Is there a song about it, Beth?
It is. So these are the White Cliffs of Dover.
Beth promised she was going to sing the song, but I think she might be withdrawing that offer. So if you look at this cliff, 100% oxygen saturations is in a good spot, nice, safe spot. And as we go down to 95%, we're still a good way away from the cliff. Where is that cliff where the patients are going to drop off the precipice and perhaps die? Well, that might be around 87, 85%, somewhere in there. So we want to keep our patients a little bit away from that cliff. So that's why our target is around 90 to 93. Because if they do suddenly deteriorate, we've got a little bit of room to respond before they drop off that cliff. So I think of this as the oxygen cliff, the oxygen precipice. Keep my patients safe by keeping them away from the cliff, but don't be giving them, if they are far enough away from the cliff, I'm not causing them problems by giving too much oxygen. Otherwise, we could just give all hospital patients 100% oxygen for their entire stay.
Yeah. And then they never go home, Ant.
Oh, that'd be jolly.
Because they'd be stuck on 100% oxygen.
Yeah. So we need to do that by monitoring. And the most important things to monitor is our respiratory rate and our peripheral oxygen saturations using the probe. Some of you will work places in critical care where you might have other ways of monitoring, like blood gases.
Yeah.
And you can also look at proxy indicators, so things that give us clues, like the patient's level of consciousness. But the good objective things is respirate and oxygen saturation. So if I've got an observation chart here, do you guys reckon that patient is getting better, getting worse, or staying the same? So that's 9 o'clock, 10 o'clock, 11 o'clock, 12 o'clock, and we've recorded their oxygen saturations there. In the interest of time, I mean, they look pretty stable, don't they?
Absolutely, yeah. They're hovering around that 91%, which we kind of said was all right, didn't we?
Yeah, that's what we said the target was.
Yeah,
they're away from the edge of the cliff. But actually what we have here is we don't have enough information to know how our patient is.
True.
So if I told you that at 9 o'clock they were on 2 litres via nasal prongs, and at 10 o'clock 5 litres via a Hudson mask, at 11 o'clock 10 litres via a Hudson mask, and at 12 o'clock they were needing 15 litres just to maintain those sats, that shows us when we actually have the information that our patient is deteriorating really badly. So whenever you record oxygen saturations, write down how much oxygen they're on, preferably writing how many litres and by what device. Yeah. Or if you're in a critical care setting, you might write the FiO2. But we absolutely need that information. Have you ever found a patient who's has SATs recorded in the chart, but it doesn't say how what oxygen they're being given? It can make it really difficult. If you arrive at the patient and their SATs are low, you don't know where they were before.
Yeah, absolutely.
So back to our friend from the start.
Yeah, so I guess just revisiting. So the case study we mentioned at the beginning of the session, that patient that presents to your clinic feeling unwell with a 2-day history of shortness of breath, with a productive cough, has got a history of asthma with no hospital admissions, that we asked you to kind of think about throughout this session. I guess the question is, have your thoughts around delivering oxygen to this patient changed at all? Has your assessment towards this patient changed at all? Have you got are you now loaded with information in order to be able to make a more confident assessment with regard to the treatment priorities this patient may need? I guess just something for you to think about.
If he's, what information do I need in order to decide whether to give this person oxygen or not? And I think it's the oxygen saturation. So Beth, what percentage oxygen would you feel the need? What percentage of oxygen saturations would make you go, I now need to give this patient some oxygen?
Good question, Ant. I think, again, oxygen saturations are a really good indicator of whether someone needs oxygen, but I wouldn't take that in isolation. I think I would still, at the same time as doing his oxygen saturations, do a full assessment as well. But sort of, I guess, that ballpark figure, if he was below sort of 92%, I would certainly think about instigating some low flow oxygen, depending, you know, on how he was presenting. How was his rest rate? What does its skin look like? You know, what are his other observations? So yeah, I don't think it's as simple as just oxygen saturations. You still have to do that full assessment on your patient.
I think sometimes a question we ask is it bad if I'm putting a lot of oxygen on? And especially when patients are first presenting with something like asthma, it's actually okay to put a bit of oxygen on and then monitor them. Because the question I think we're all really worried about is what if the patient's got COPD?
That's right.
What happens to a COPD patient if I give them too much oxygen? Will they explode?
I'm not sure. I wonder what the guys in.
What's the problem with giving high FiO2, a high fraction of inspired oxygen, to a COPD patient or a CO2 retainer?
They retain CO2.
They start retaining carbon dioxide.
Why? Because we know it's bad, right? We know we don't want to give high levels of oxygen to a patient who's a CO2 retainer. But it's interesting to ask ourselves why. Because I think sometimes people do think that the patient's going to explode or, you know, blow up in the bed or something like a balloon. But that's not what happens.
They won't. They won't blow up.
Thank
Absolutely.
goodness.
Phew, because that would be really messy. No, with our COPD patients, if you are faced with someone who has got COPD but has very low saturation levels, sort of, you know, below 88%, absolutely give them oxygen, because they're hypoxic, and a little bit of oxygen can improve their situation. It might be that they have an infection, an exacerbation of COPD because of an infection, and they need that little bit of extra oxygen, remember, for that cellular metabolism, so that you're not going to blow anyone up or kill anyone by giving that tiny bit of oxygen to remember to target those sats. So think of that cliff again, but your point of falling off that cliff with COPD is probably around 85 to 89%.
The way I think of it is, can a COPD patient die of hypoxemia? Yes, they can. It's just they tolerate a bit of hypoxemia better. So like Beth said, the cliff face is in a slightly different spot, but the problem can be the same. And what we're worried about is if they're a CO2 retainer, we're worried they may have lost they may be breathing on a hypoxic drive. So normally for the stimulus for Beth to take a breath is her CO2 level rises. And that's what cues her brain to go, okay, time to breathe. But with some of these patients who have chronically high CO2, their body adapts and they start to have an hypoxic drive. So the stimulus for them to breathe is when their oxygen level drops. So the worry is if we give them too much oxygen and take them above that level, the worry is that they'll stop breathing, i.e. the thing we want to monitor for when we've got patients on oxygen who are COPD is we monitor them for apnea. So if a COPD patient comes in, like our friend there, I can still put oxygen on him. I just need to put monitoring on them and keep a close eye so that if their breathing starts slowing down, I know that I can back off. So does anyone have any questions or comments or stories? Has anyone seen an interesting patient needing oxygen? I don't need to ask, has anyone seen a patient needing oxygen, because with the amount of COVID that's been through, I know that everyone's been seeing some.
Hi. Sorry. We just regarding the COPD, we had an elderly male during our last wave of COVID who had COPD and had COVID. He actually, his requirement was less than 85%, and we didn't catch this initially when we came in. So every time we would deliver high flow O2, he would like knock out. And then, yeah. And then after some time so this was during the weekend, and then during the week when our doctors came in, then they picked it out that every time he had to remove his nasal, the apple, then he would like, his GCS would pick up. Yeah, so that was an interesting one, because we couldn't pick out that he needed less than our normal, which was like, less than 85%, he would actually wake up.
So I ask a question? Oh, sorry, carry on.
So we actually had to just remove the whole high flow and just deliver with the nasal prongs with 3 liters. He was okay. Then he got transed out.
Yeah, because my question to that would be, was he on high flow because he needed he obviously didn't need the higher oxygen concentrations, but he may have needed the flow in order to help with his breathing?
Yeah. We actually had to end up right with CPAP, but he did it like, he would come out of his coma and then he'd go back to it again. Like he was a bit back and forth with CPAP and then EVO.
Yeah. Can I ask, just out of interest then, with that gentleman, was it ever discussed that you would keep him on the EVO with higher flows, but dial the oxygen down to 23% or something?
Yeah, we actually went right down. Yeah. But
and that
he's like the only thing that we were able to pick out was his GCS cap and his CO2 retention.
Yeah, that's great. That's a really good illustration. Thank you.
It's great, Addie. And sometimes this bit is missing from the history, and it doesn't surprise me, because when people present to hospital severely short of breath, they're not really got enough words to be able to sometimes explain their history either, even if they do know it.
Yeah.
Thanks, Addie.
Awesome. Any other questions or queries, or I guess suggestions for the next NurseTOK?
So we've started that Facebook group to share, and one thing, it's so you can know when the next talk's coming up, but it's also so you guys can talk, that we can talk as a community of practice, so as nurses in multiple countries, because something we've noticed as you go from one Pacific country to another, sometimes you guys are facing similar challenges, and sometimes the solution that works in one place is going to be helpful in another, so a great place to share that. So if anyone wants to post any ideas or requests in this chat or in the Facebook group, that'd be great. We'll probably put a questionnaire up in the Facebook group for like a poll, so people can put some ideas in.
And the other, what we also might do is to the Facebook group add, you know, that oxygen ladder chart. If you think that would be helpful for you to have, we could easily post that resource as well, and any other resources that we've sort of shown you today that you think may help you in your future practice.
Well, in the interest of time, because we've gone a bit over time again, thank you very much, everyone, for joining us. So we've got lots of Fijians, so we must say Vanaka Vaka level. And we hope to see you next month for Nurse Talk. And until then, keep safe and keep doing the great work that everyone does.
Thank you.
See you next time.